everybody. This is Misty. Thanks for joining us this afternoon and taking the time out of your schedule. Today we'll be reviewing the quarterly results for quarter 2 of year 2 of the waiver. So specifically that time period is January, February, and March of 2018. So the first area, one of our newer performance measure areas, since we came over to the Department of Human Services, we had to add some administrative authority performance measures. And so you'll see those here. The first one is new applicants enrolled by the operating agency according to 674403. And so we look at several things here. This requires the individual to be in a home and community-based setting. It requires the person to have a level of care, a care plan, and to be approved by the Division of Economic Assistance. And so we look, also requires cost of services. So we look at all of those things in order to establish the performance compliance for this one in particular. So as you can see here, we are at 93%. We did have 12 who were not compliant. We had 5 that did not have a care plan on file. We had 3 in which there was no care plan and no cost of services. And we had 4 that had just no cost of services. We do 100% review of the initial approvals for this one. So you'll see here, like I mentioned, that we had 178 new approvals this quarter. And again, 93.3% of those had everything that was required available at file director. So the next is the designated agency maintained program participants with an approved waiver limit. This is one that we'll look at in September of each year, so we don't have the data on here, but essentially we'll be looking at the number of people that are projected in our waiver application and then the number of total unduplicated participants that we serve during the year, and that would be what we'll be looking at for that one.
Hang on, everybody. This is Leslie. I'm just going to check and make sure everybody's muted. It sounds like the audio isn't great for everybody across the state. Okay, I'm not sure why the audio isn't sounds good. Okay, maybe just a bit closer.
Okay, I'll sit closer and hopefully that'll help. And then the next is designated agency maintained program expenditures with an approved waiver limit. Again, this will be reviewed annually around September, and so we don't have the data for today's meeting, but again, we'll be looking at the total expenditures that we reported when we sent out our waiver renewal in 2016. We'll look at the total expenditures that we said we would spend versus the total expenditures that we did spend to determine our compliance in this area. The next one is related to our exceptions process, which is service plans exceeding the cost of nursing facility care that were approved according to the exceptions process.
I don't know why. So weird. Again.
Okay, well, since everybody's here, Leslie, not me, she's going to take over.
Okay, I'm not sure, Barb. Maybe if you can hear us okay, maybe follow along with the presentation we sent out via email prior to the webinar. The only other suggestion I can think is to shut down and start back up again. So back to the presentation. Service plans exceeding the cost of nursing facility care that were approved according to the exceptions process. For last quarter, we had 37 that we reviewed, and out of those, 32 were in compliance, which meant 5 were not. We are going to be updating the exceptions plan policy and procedure because We realized that we didn't have the submission requirements included in that. And so I believe a lot of staff didn't realize that they needed to submit an exceptions request during the annual review process. So we'll be updating that soon and getting that sent. Okay, so moving on to level of care. As you all know, we make the assignments the 15th of the month, and reviews are completed by the last day of the month, and then the remediations are due the following month on the 10th. For new applicants who had a level of care determination prior to receiving services, there were 178 reviewed, and we were 100% in compliance with that performance measure last quarter. For consumers who received an annual level of care determination within 12 months of their last level of care determination, we reviewed a total of 292, and we had a 91.44% compliance rate, so that's great. Out of the ones that were not in compliance, there were 7 with staff errors, 2 with MRT errors, 4 where the consumer was unavailable, 11 where we were unable to obtain the physician's order, and 1 that was unable to determine. For consumers whose level of care determination included the required documentation, there were only 3 that did not comply with this performance measure. We don't have any data, but it's either the CHA was not on file or the physician's order was not in file directory. For level of care determinations, initial and annual made where the level of care criteria was accurately applied, we review 30 every quarter, and we had 100% compliance this quarter as well. And you can see that with last year's information included on this slide that we have been in 100% compliance with this performance measure for quite some time. Okay, as long as there's no questions, I'm going to move right into the service plan performance measures. For consumer care plans that addressed all assessed needs, we were at 82.5% compliance with this. As some of you might remember, we are attempting, our goal is to get 86% compliance, and this is one of our performance measures that we've kind of struggled with over the years, and we've kind of had some increases and decreases, as you can see in year 1. We did identify during our last waiver review committee that we need to provide some of our newer staff the full CHA training that they have not yet received, and so that has been scheduled for all of the staff that have started since, I believe, last June. So that will certainly help with that. We would also encourage anybody that has any reoccurring remediations to review the webinar that we have out on the LTSS new staff training website. I can certainly send that link out to everybody after the webinar, but there are 2 recordings available. One is on the HOPE waiver itself, and the other is a review of the care plan and what is required to be on the care plan for compliance with the waiver requirements. And so we thought that might be helpful for any of you that maybe haven't had a full care plan training at this time. But the care plan training will be a part of the advanced CHA training that we're doing next month for newer staff. Okay, the next one, consumer care plans that address health and safety risk factors. This is a subset of the prior performance measure, and so our percent in compliance is a little bit higher with this one. But again, the caps were not addressed in 5 of the care plans that were reviewed. For care plans that address personal goals, we had almost 98% compliance this quarter. There were only 2 that were not in compliance, and 1, the personal goal was listed but not addressed in the goals and strategies, and the other, there was no personal goal listed. For consumer care plans that are developed in accordance with the state's policy and procedure, remember that this is all of the service plan performance measures kind of all put together, and so this one is always going to be the lowest performance measure we have because it's a collection of all the others, and we have almost 82% compliance with this. For consumer care plans that were updated or revised annually, we're at almost 97% compliance, so good job. For consumer care plans that were updated or revised when the consumer's name changed, we're at almost 97% for that one. For consumers who receive services in the type and scope specified in the care plan, again, really high performance at a little over 98%. For consumers who receive services in the amount, duration, and frequency specified in the care plan, we're at 97%. Again, very high compliance. For consumers who are offered choice between waiver services and institutional care, we're at 100%. This, again, just as a reminder to you all, is dependent on whether the care plan is signed or not, because these statements are on the back of the last page of the care plan. And this consumer is basically signing to acknowledge that they've been given that information and those choices. For consumers who are offered a choice between providers, again, 100%, and that applies to this performance measure as well. It's on the last page of the care plan. Okay, again, as long as there's no questions on the service plan, I'll go right into the health and welfare section. For waiver consumers who received educational information regarding abuse and neglect and exploitation, we had 100% compliance in Q2. For abuse, neglect, and exploitation investigations initiated within the specified timeframes, we had a total of 14 calls on waiver consumers during that time frame, and 13 out of 14 were in compliance at almost 93%. Oops. One. For waiver care consumers who've had service plans which address backup plans and emergency preparedness as appropriate, again, very high compliance at almost 98%. For abuse, neglect, and exploitation investigations that were reported appropriately, we're at 100% compliance this last quarter. Again, great job with this one. For complaints regarding providers that were addressed within the required timeframes, we had a total of 20 that we reviewed for Q2, and out of those, 17 were in compliance for 85%. That's real close to our 86% threshold. I'm trying to remember off the top of my head what the issue was the 3, but I believe it come back to not closing out the case. So if you remember in the complaint policy, there needs to be a complaint resolution journal, and if there isn't one, we have to count that as not in compliance. So be sure you always have a resolution journal note whenever you are following up on a complaint about a provider. For critical incidents where appropriate follow-up occurred, out of 26 reviewed, there were 22 in compliance. Again, we're not quite at that 86%. But it's a big jump from last quarter, so thank you for that. Great job on those. I would recommend to anybody that, especially those of you that maybe don't get very many critical incidents, and you get one, that you pull out in the binders that we sent out to all of you last spring sometime, I think. There is a flow chart for every single critical incident type for waiver, the death, restraint, seclusion, serious injury, and missing person. There's very specific guidance that is listed on those flow charts that indicate what the follow-up requirements are, as well as what the documentation requirements are. And so I'd encourage any of you that are unsure of the proper policy and procedure, or those of you that don't get these very often, to pull those out and kind of look at them when you're completing that documentation, so that you are sure that you get all the required information in there. Sometimes it's a struggle for the critical incident team to actually be able to determine compliance, because maybe the journal note didn't indicate where the person had passed away, and there's different requirements based on where the person passed away and where the information came from to LCSS. And so just really encourage you to look at those and make sure that you're completing all those requirements when you're following up on a critical incident report. For consumers who were not restrained or secluded while receiving waiver services, this last quarter we had 100% compliance with that. And for incidents of restraint or seclusion where appropriate follow-up occurred, of course, we had 100% compliance with the former performance measures, so there were actually none to review for this in quarter two. For consumers who received age-appropriate educational information regarding preventive health care, we had 100% compliance with this performance measure as well. For consumers who received age-appropriate preventive health care, we had, again, 100% compliance. Okay. Moving on to qualified providers. If any of you have any questions during this, feel free to unmute yourself or type a question in the Q&A, but unless I hear from anybody, I'm just going to keep going through this because we have another presentation that we want to review quickly with you as well. For new licensed providers that initially met licensing standards, there were 2 this last quarter, and they were both in compliance. This is reviewed yearly licensed and or certified providers by provider type that continually meet state licensing standards. This is reviewed yearly in September, October timeframe, so we'll be looking at that here soon. For non-licensed and non-certified provider applicants by provider type who met initial waiver provider qualifications, we did have 1 this last quarter, and they were also in compliance. Again, this performance measure is reviewed in September, October for non-licensed, non-certified providers by provider type who continue to meet waiver provider qualifications. Non-licensed, non-certified providers by provider type who met training requirements is also reviewed in September, October, so this will be a part of next quarter's review. Financial accountability performance measures, waiver service claims that were submitted for approved services. We reviewed, there were a total of 7,907 claims. Out of those, we reviewed 367, and all 367 were in compliance with this performance measure, so that's great. For waiver service claims that were submitted for consumers that were enrolled in the waiver on the date the service was delivered, out of 7,970, we reviewed 367, and again, all of those were in compliance. For the number and percent of survey respondents who reported they received the services or authorized for this last quarter, there were a total of 322 surveys. Out of those, we reviewed 176, and there were 164 compliance. And the only reason the title at the top is red is because we always, Misty and I, after this review is done, we follow up with the provider and we request the notes for the months in which we're reviewing to ensure that there's documentation to support the services that were paid for. And so we just haven't had time to get all of the documentation back from the providers and had time to review those and update this slide. But our performance might go up based on that review, and it might not. So we'll see where we get with that one. Another that's completed annually in September, October is in-home service claims paid according to the reimbursement methodology. For rates establishing utilizing cost reports that are consistent with the rate methodology is also reviewed in September, October. And then finally, rates utilizing the state plan fee schedule and or usual and customary charges that are consistent with the rate methodology will be reviewed.
Okay, sorry, I don't know if anyone can hear me, but this one usually also is the one that lags a little bit because we do have to request some documentation and look further into it. So this has been updated. The quarter 1 wasn't in the previous presentation, but we did review 114 for that, and there were 114 in compliance. This time, basically what we do is we ask providers to submit or attest to the fact that they billed within the usual and customary charge, which would be what they would bill to a member of the general public, that they don't exceed that cost when they bill Medicaid. The other thing that we are required to look at for this one, though, is the rates
that would be on the state plan fee schedule. That we need to ensure that, number one, they're authorized services, but number two, that if Waiver pays for something that is on the state plan fee schedule, that number one, the DME process was followed, and number two, if it was, that the waiver would not pay more than what's on the state fee schedule. And we have all, I think we have about 4 or 5 that are non-compliant so far this time. We're still waiting on provider attestations for some of them, so that's why this one isn't complete. But I just want to remind everybody of the DME process and the importance of following that. Basically, anytime before you're going to authorize a piece of medical equipment or supplies, you need to pull out that DME process chart to find out if it's something that's covered by Medicaid or not. If it is covered by Medicaid, you need to make sure that you work with the consumer to actually get that authorized, or that they work with the DME provider to get it through the state plan versus the waiver. And if it's a situation where they've already met their limits for the Medicaid state plan, that we should not be authorizing more than what Medicaid would pay. So for example, I think, this last quarter, this isn't one that was pulled, but just as an example, we had someone who needed to replace like the joystick on their wheelchair, I believe it was, that's something that Medicaid wouldn't pay because it's a covered service, but Medicaid would not pay for it because they'd already had it replaced in the last year. However, it was a piece of broken equipment. The person really needed it to be able to remain safe at home, so the waiver, we decided, could cover it. However, we could not cover the cost at more than what the state plan fee schedule showed. So that's just an example. If you find something that's not on, you can't find it on that DME process, you need to find out the HCPC code and submit that to me, or look it up in the fee schedule to determine if it's covered. So again, just a reminder, we did have, I think, 4 or 5 so far this quarter where the DME process wasn't covered or wasn't followed, and or what the waiver paid for the piece of equipment was more than what the state plan fee schedule showed. So just a reminder of that process, and it's important that we try to follow that to ensure cost neutrality with our waiver.
Yeah, so that's the Q2 results. Overall, I thought they were really, really good this quarter. Just the 2 areas, I think, are the assessed needs, which, we really didn't make any, we're not going to be making any changes to how we're doing that, because we're going to be moving into using the TheraP system, which will kind of eliminate some of the difficulty in making sure your caps and services are addressed between the CHA and your written care plan, because it's all going to be within the system. And then, of course, critical incidents, again, just as a reminder to pull out those flow charts and make sure you're getting all the documentation requirements and the follow-up done according to policy. If you just give me a minute here, I'll pull up the other presentation. Okay, so as you guys know, we submitted a HOPE waiver amendment last summer, and we received word from CMS that our waiver was approved with an effective date of August 1. So the purpose of the amendment was a couple of different things. First, we added community transition services. Community transition supports will sustain services currently available through the South Dakota Money Follows the Person program. That program will stop transitioning individuals effective December 31st, 2018. So we'll continue to use and to refer individuals to MFP. until they no longer are taking any referrals. And then our community transition supports and coordination services will kind of take the place of the MFP program. The community transition coordination services will also sustain the Money Follows the Person program and assist with the transition of the waiver participants to a less restrictive environment. The next two services was to the addition of two residential options. First, the addition of community living home as an available service to provide another home and community-based settings option to increase provider capacity, specifically in our smaller rural South Dakota areas. And then also the addition of structured family caregiving service to provide an opportunity for Hope Waiver participants to reside in a family-style home setting, which will also then increase our provider capacity.
Okay, so hopefully this sounds better. I think as long as I put the computer right in front of me, that maybe there isn't so much feedback, but if that's not the case, let me know and we'll make Leslie do the whole presentation for this one too. Okay, it's better. Okay, good. So I'm going to talk about community transition services. Leslie just kind of very briefly covered those, but we're going to just talk about them more specifically. So most of this information, I think, was provided, if I recall correctly, by an email when we first submitted the waiver amendment for approval. So if it looks familiar, that's why. I don't think we formally presented on it, but some of you have likely read through the information. We just want to bring it to your attention again today because we haven't done a lot of training on it, and just kind of talk about where we're at with the new services and kind of the next steps. So like Leslie mentioned, we're going to continue to do MFP referrals the same way because we do get actually more of an enhanced match from the federal government when we utilize that program, and so we want to utilize it as much as we can. There are going to be some situations that someone would be available or eligible though for community transition supports, even if they're not eligible for the MFP program. So just so you're aware of that as well. So as far as the community transition supports, these would be things like a security deposit required to obtain a rental lease, moving expenses required to occupy a residence, one-time non-refundable deposits for installation fees for utilities, water, telephone, those types of things, one-time residential cleaning or pest extermination costs, non-medical transportation necessary to the transition, some essential household items necessary for a successful transition as determined by a needs assessment. Those are just some things that we can cover through the transition supports. And again, most of these things are available through MFP, so it's pretty similar. There is, I would say, a little bit more flexibility in the service that we set up with the help of the MFP program input on their experience. So we did base that on some of their past experience. The total cost of all items or services purchased shall not exceed $5,000. So a little bit more about the essential household items. So that might include things like furniture, small appliances. It could be the first initial setup for groceries, household supplies like hand soap, detergent, toilet paper, bathroom and kitchen linens. The community transition case manager will accompany the consumer to purchase these types of items, and the total cost of the essential household items must not exceed $500. So the transition supports altogether, the limit currently is set at $5,000, and then the essential household items would be at $500. So the other piece of the community transition supports is really the community transition coordination piece, and really this is essentially some additional case management for individuals who are transitioning. So this service is available to individuals that are transitioning to a less restrictive setting. So one difference between the way we've set up this service and how it is in MFP today is that we would allow someone to, for example, move from an assisted living to their own home. Currently, the MFP program allows people only to transition from places like a nursing facility or other institution into a home and community-based setting. But we would allow, just as long as it's a less restrictive setting,
The primary thing is going to be, for example, from an assisted living to home, or perhaps assisted living to one of our new residential options that Leslie will be talking more about in a few minutes. The other difference is that the community transition coordination that we set up with the HOPE waiver is that it only requires one Medicaid eligible day. So the MFP program, I believe, requires 90 Medicaid eligible days. And so again, there might be, our first step is always going to be to refer any of these types of transition appropriate cases to MFP. But these are a couple situations in where they wouldn't really be able to serve the individual according to their guidelines, and they might get referred back to us because of that. So again, if they're just going to a less restrictive setting, or they've only had one Medicaid eligible day. This particular service will assist in identifying, selecting, and obtaining paid and unpaid services and integrated housing options. So we'll be utilizing an externalized case manager, so not you guys up front. This will be some of the currently enrolled providers for the DD case management will serve hopefully as our community transition case managers. And they'll really be working with these individuals to ensure that there's a successful transition, again, by helping to identify, select, and obtain the services needed, helping to find housing options, and just making the participant aware of the services that are available and getting those in place. So it'd be available for up to 180 days prior to the anticipated transition, and then for 90 days following the date of waiver enrollment. So once they're transitioned and enrolled in the HOPE waiver, that externalized case manager is going to continue to follow this person and make sure that things that might get in the way of their transition are addressed. The HOPE specialist, or the LTSS specialist that has the HOPE waiver case, would still be doing their regular case management. But again, just really making sure that this person is going to have a successful transition by doing a lot of having them have a lot of case management available.
Just real quick, Misty, I don't know if you said it or not, so I apologize if you did. But on that first bullet, I just want to make sure that everyone knows that it's just to a less restrictive setting. So currently, the MFP program restricts individuals to moving from nursing facility to a less restrictive setting, but we set up this transition service to allow anybody from a more restrictive to a less restrictive setting. So for example, we can transition individuals from an assisted living into their own apartment and community if that's what they want. So just wanted to point that out in case that wasn't clear.
Okay, so let's see here. So a little bit more about the community transition coordination or case management. Of course, it should be person-centered and would include things like an initial assessment and the ongoing reassessment of the individual strengths and needs, transition care plan development, evaluation, and revision. So again, what's this person really going to need to transition successfully back into the broader community, into their own home, and really making sure that that can happen. It would be assistance to access service providers, maybe even some provider development if necessary, assistance in identifying and securing integrated community housing, information and education on the HOPE waiver service options, and ongoing monitoring of the transition care plan and implementation. So as far as kind of the next steps and where we're at with the community transition, again, like we've mentioned a couple times, we really encourage you to continue to follow the MFP process. So if you receive a referral for MFP, or I'm sorry, for a case that seems appropriate for transition, you'll want to just go ahead and refer that to MFP if the referral, of course, isn't from MFP. Continue to refer those. Like I mentioned, we do have an enhanced match for the waiver services when we do utilize MFP for HOPE waiver, potential HOPE waiver participants. And then, of course, if not eligible for MFP, the program manager for that program will refer them back to LTSS. LTSS will then assess for the community transition services and assist with getting a provider for that. So what we're really working on in this area, we do have potential providers that are enrolled. Like I mentioned, we plan to just go ahead and use those that are currently doing the DD case management or are able to bill for this service.
We have had minimal contact with them to this point, so we need to work with them to understand this service. So what we're really working on is the development of the provider provision and policy. So basically like a supplemental agreement to kind of outline the requirements of that provider and then policy for staff. So we're just kind of trying to get that finished up so that we can really get the service going. For the most part, like I mentioned, we'll be working with currently enrolled providers to transition consumers that would potentially be eligible for the home waiver. So this is just kind of a flow chart that kind of how we anticipate the community transition working. And so essentially we'll get a referral for transition. We would complete the South Dakota Choices screen unless we need to refer them back to MFP, but we'll say we did that already. If, according to that South Dakota Choices screen, it looks like the individual will meet the waiver criteria, we would move forward with getting a level of care, a preliminary level of care from the nurse consultant manager, and then move forward, as you'll see in the chart here. I think this is still accurate. So again, this is just an area we need to just double check. We created a lot of the stuff before when we were getting ready to submit the waiver amendments. So we'll have to just double check and make sure it's still the way we want our policy to be written. So this is just kind of a draft.
There's a question in the Q&A. It says, if we get a transition referral back from MFP, do we send that up to you, Misty, Leslie, or how do we handle that?
Yeah, I'd say at this time, if there's, while we're getting started on these, if there's potential referrals, yeah, if you would just loop Leslie and I in, we'll work on helping to locate a provider and just getting a feel for how the service is going to work. So yeah, we would appreciate that, getting looped into them.
Okay, moving on to...
Are there any other questions about the community transition services? Okay. Well, I'll pass it off to Leslie to talk about the new residential option.
Okay, starting with the community living home service. Community living home provides an alternative long-term care option to individuals who meet nursing facility level of care and whose needs can be met in a less restrictive environment. The residence itself must be owned, leased, or rented by the community living home provider. They also must be licensed by the Department of Health. The community living provider must ensure the basic health and safety needs of the waiver participant are met 24/7. And the maximum number of participants receiving community living home services in any one residence may not exceed 4 people. And they're reimbursed at a daily rate that has 3 tiers dependent on acuity and behavior. And so these are very similar to how an assisted living is structured, just on a much smaller scale. We have had some providers communicate with us. We've had some conversations out there of people potentially interested in building and or creating a community living home, and then we've also been working with the Department of Health to determine some of the licensure requirements, and then Misty and I have been working on the policy and procedure. So just for the community living home service, what's included in the rate? Routine intermittent personal care, supervision, queuing, meals, homemaker chore, medication management to the extent actually permitted under state law, and then other assistance with IADLs are all included in that rate that we have set. However, there are other services that can be authorized based on an assessed need, and that includes the community transition supports and coordination that Misty just talked about, adult companion services, adult day services, in-home nursing, specialized medical equipment and supplies, and nutritional supplements. Respite care can be authorized if or when the community living home is also the full-time residence of the owner-operator. And then extraordinary personal care that needs that exceed intermittent daily assistance when the participant requires more than one person to assist with ADLs can also be authorized. just a note there at the bottom, services must be consistent with the participant's assessed needs and reflected in the person-centered care plan. We do have a question here. On the algorithm, it says to get the physician's order. I thought that wasn't needed anymore. Also says nurse consultant, but Misty said nurse consultant program manager.
Are you talking about the flow chart? Is that what you mean by algorithm? Yeah, I'm thinking that's probably what you're talking about. Like I mentioned, this was something, yes, the flow chart. Yeah, just in looking at this again, quick, it does look like there may need to be a couple of updates, so we will work on those and get them out.
Yep. Another question, how do we plan to monitor respite care to make sure the respite care time is only going towards the authorized consumer? Well, for community living home, really anybody living there should be receiving the community living home service, and so the respite would really be.
So the only time in a community living home where respite care would be allowed
is if the person is a full-time resident of the owner, or if the owner-operator is also a full-time resident of that setting. This is typically going to be a situation where, it's actually, there's kind of a complicated situation that where we would actually be authorizing structured family caregiving in a community living home, and that's probably the situation in which the respite care would be authorized. So I wouldn't get too caught up in the details of that. If we have specific situations, if there's respite care in a community living home situation, you could sure run that by us, and we can determine the best way to handle it and make sure it's, being completed as appropriate.
Let's see. Okay, on the next slide, what may not be authorized for separate payment include meals, homemaker services, chore services, ERS, and environmental accessibility adaptations. None of those will be allowed or authorized for separate payment for a community living home. Payments made for community living home services are not made for room and board, items of comfort or convenience, or the costs of home maintenance, upkeep, and improvement, just like the assisted living services. Okay, structured family caregiving then also provides care and supervision for a participant through a cooperative relationship between the participant, the principal caregiver, and the participant's Hope Waiver case manager, and as well as the Medicaid enrolled structured family caregiving provider agency. It also provides an alternative long-term care option to individuals who meet nursing facility level of care and whose needs can be met in a less restrictive environment. The home must be the primary residence of both the principal caregiver and the waiver participant. It can be owned, rented, or leased by either one, but it cannot be owned, rented, or leased by the Medicaid enrolled structured family caregiving provider agency. The number of participants in structured family caregiving cannot exceed 2 participants in any one private home. And the structured family caregiving principal caregiver may be a related family member or a non-relative fictive kin. If the structured family caregiving principal caregiver is not a related family member or a fictive kin, the home must also be licensed by DOH. And that's kind of what Misty was getting to earlier, in that we've provided this opportunity in a situation where there's only 2 people receiving care in a home-like setting. If the person is not related or fictive kin, we allow structured family caregiving services to be authorized, but the home itself, the setting, has to be licensed as a community living home because of the non-relative, non-fictive kin relation. There is no relative or fictive kin relationship. So for structured family caregiving, what's included in the rate: routine intermittent personal care, supervision, queuing, meals, homemaker chore, medication management, and other IADLs. Other IADL support. What can be authorized for separate payment include the transition supports and coordination, adult companion, adult day, respite care, ERS, in-home nursing, specialized medical equipment, supplies, environmental accessibility adaptations, and nutritional supplements. So all of those can be kind of add-ons based on the specialist assessment of the person's needs. And the Structured Family Caregiving Provider Agency will also be doing kind of a review on the home. And so between all of those entities, the person being supported, the principal caregiver, the LTSS specialist, and the provider oversight agency will all need to, work together to determine what the needs are and what services are going to be authorized. What may not be authorized for separate payment includes meals, homemaker, and chore services. And again, payments made for structured family caregiving are not made for room and board, items of convenience or comfort, and the cost of home maintenance, upkeep, or improvement. So here are the rate tiers that have been developed for both community living homes and structured family caregiving. You see the criteria there in the right column for how a person is determined, what tier the person is determined to fall into. I don't know if all of you have noticed, but we have incorporated this into the CHA assessment. So some of you may have seen at the very bottom of the CHA that there's a RUG score, and that's what that RUG score is there for. We're going to be using that RUG score to determine where in these three tiers the individual might fall, so we can determine payment if they are going to be using one of these two services. Just to kind of help separate the two and give you guys a visual of the differences between them, we put this chart together so that it could, at a quick glance, you can see kind of what the differences are. I'm not going to go through each list, but I thought it was really helpful to kind of see them side by side. And then we also have kind of a flow chart to help people understand the differences between them a little bit more. So as you can see there at the top, the very first question we need to ask is the place of service, the setting itself, the full-time residence of the principal caregiver? If it is not the full-time residence of the principal caregiver, it automatically becomes a community living service. If it is the full-time residence of the principal caregiver, then we need to ask, are there more than 2 care recipients living in the home? If more than 2 people are receiving a service through LTSS, then it automatically again becomes a community living service, because there's a maximum of 2 people that can be receiving structured family caregiving in any one setting. If the answer to that question is no, then we have to ask if the principal caregiver and care recipient are related or fictive kin. If they are related, it's just your basic structured family caregiving services there over on the right, and we will have oversight by the Medicaid enrolled provider agency. However, if they are not related and or fictive kin, they still will be allowed to provide structured family caregiving services, but they also need to be licensed by the Department of Health, as well as having the oversight by the enrolled Medicaid agency. Hopefully that makes it a little bit more easy to understand the differences between the two residential models and how you as the specialist can kind of determine which might be a possibility for any of the residents or any of the consumers that you're assigned. For both the residential services, our next steps include provider recruitment. Some of you may remember this, and some of you actually attended, but we recently had 3 presentations across the state. We invited all of our current in-home providers to attend that, and we actually had a pretty good turnout. Some of our providers have let us know that they're not interested in providing this service, and some have indicated they are interested, and so we just need to kind of take the next steps with enrolling those providers as being able to provide that service. We also are working on identifying kind of a target group and or specific consumers for kind of our initial group of people to try to get going with this service. We want to be really successful with our first few cases, and so we're looking for new referrals that are already kind of set up this way, especially for structured family caregiving. If they're already living with a family member and the family member is already providing their care, they're kind of a perfect scenario for a referral for structured family caregiving services. And then, of course, Misty and I are also working on the development of the provider provision agreement and the policy for staff. We have a question in the Q&A. It says, will the ombudsman be able to go into the structured family caregiving services if needed? Actually, no. The structured family caregiving service is more of an in-home model, and so therefore, LTSS specialist and the provider oversight agency would be the individuals assisting in any situation where there's a complaint or issue in a structured family caregiving home. However, community living homes are set up to be in a setting where ombudsman will be having a presence. At this time, we did not set it up to have a required monitoring schedule like the assisted livings and the nursing homes, but they will be following up on any consumer complaints that we get from anybody that's residing in a community living home. That is the end of our amendment presentation. We just wanted to kind of talk to you about the 4 new services and let you know kind of where we're at right now. Are there any other questions about either the second quarter results or the amendment services that we just reviewed? While we wait to see if any of you have any additional questions, we are curious about your participation on the Therap demo the other day, and would love to hear or read any feedback that you have about what you saw or heard during that presentation. Feel free to type in the Q&A or unmute yourself if you have any feedback to share. We'd love to hear it. Okay, so a question in the Q&A says, how far down the road will these be available for us to utilize?
So we don't have really an exact time frame for the community transition services. Like I mentioned, if you do have situations that you feel would be appropriate, people that would be appropriate for that service, again, do a referral to MFP. If we get a referral back, initially until we get everything really ironed out, we do potentially have some providers that could potentially provide that service. So I think for the beginning, we'll hopefully just kind of determine those on a one-to-one basis and really try to get them set up with one of those providers if possible. So again, if you just want to reach out to us if you have some that are appropriate, that's specific to the community transition services. As far as the structured family caregiving, we're really still working on provider recruitment, and we also have some issues with when a provider can bill. We've been working with BIT and Medicaid for quite some time we were hoping to have these available at the onset of the implementation date, but unfortunately that didn't happen. And so we're kind of shooting for, I would say, October 1st, potentially we could, if we would find a provider, have some of the services available September 1st. But again, it's kind of pending kind of 2 things. The provider being able to enroll, and until things are set up in the MMIS system, there's a possibility that they won't be able to. So again, it's just really kind of a unknown at this time, although we're hopeful that within the next couple of months that structured family caregiving can be utilized. And then there's also with the community living homes, again, we're working with BIT, but the timeline for that is out even a bit further. So we're shooting kind of, I would say, for January 1st for potential consumers to be able to utilize that service. but again, that's kind of pending providers and provider development.
Okay. Next question in Q&A says, are community living homes and structured family caregiving providers able to charge the participant for rent per se? And on the presentation, it does indicate here that it says payments made for structured family caregiving are not made for room and board. It's the same on the community living slide.
So for the structured family caregiving, it would be set up similar to the in-home services. They can, as far as the cost share, they would be able to bill the participant. They come up with an agreement as to the rent, room and board. For the community living home, it's set up more like the assisted living, where the individual will just be able to keep $60 and the rest will go to payment, which would go towards room and board. So it's a little bit different for both services. The structured family caregiving is set up more like an in-home, and the community living home is set up more like an assisted living.
Okay, next question. Some cities have ordinances in place for operating these out of your house. Will we be complying with city ordinances, or is it up to the individual to go through that process?
I would say at this time it would be up to the individual to ensure that they're compliant with the ordinances. As far as the structured family caregiving, the oversight agency would likely maybe also play a part in that to make sure that the homesteading is appropriate and things like that.
I'm not seeing any feedback about our therapy demo, so I would just encourage any of you, if you have, good, bad, or otherwise, we'd love to hear your feedback about the demo. So if you would kind of route those up through your supervisors, we'd really appreciate hearing your thoughts about it here in peer. Well, good. Thank you, Karen. We appreciate that. Karen says she was encouraged about therapy, so I appreciate hearing that. But again, whether it's positive or not positive, even if you have concerns about anything that you saw or heard, we'd appreciate to hear that too. So please share that with your supervisors if you can.
Real quickly too, we did notice after the therapy demo ended yesterday that there was a question in the Q&A that we kind of failed to answer. I guess we didn't notice it until after it was over. It was regarding whether or not intake would be within therapy. And so our plan really, at this time, we're working with therapy kind of to prioritize what can be rolled into therapy to begin with. The intent, for the most part, is to eventually transition everything from SAMS into therapy, but of course that'll take some time. We're prioritizing the authorization process and potentially the care planning process. So the things that you saw yesterday are the things that we're really working on to get going sooner than later. However, it is the intent that at some point the intake will hopefully be within therapy as well.
Okay, we're just over our time. Are there any other questions before we end the webinar today? If you do think of other questions you have about the new services, or again want to give us the feedback, feel free to email Ms. Uri or talk to your supervisors. Otherwise, I hope that you all have a great rest of your day, and we'll talk to you soon.